the Health and Thank you, Memo. My name is Leal Gaspar Herrera, and I am with the Health Improvement Partnership of Santa Cruz County, as we serve as part of the PATH Collaborative for Santa Cruz County. And so it's really a pleasure to have you all here with us today as we focus on eligibility screening, risk identification, and preventing duplication of services in ECM. And so this is an area that comes up often in practice, especially when trying to understand what services a member is already receiving and how to ensure ECM is being provided in a way that complements rather than duplicates those supports. And so that's what today's session is really about, taking a more structured and intentional approach to screening, from identifying existing resources or services, to documenting non-duplication and supporting coordination from the very beginning. And so before we get started today, we are going to launch a quick poll just to get a sense of everyone's experience within this topic. And let me get that pulled up. Okay, so we have that launched right now. And then we'll just take a second to get that going. And then while that is going, we can go into our next slide. Beautiful. And then I just briefly share who's with us today. So we have myself, and then we have Brittany Say, our Programs and Operations Director, and Memo, our Operations Coordinator, who are both supporting me on today's call. And then we are also joined by Esmeralda and Darlene, who are leading today's session. And so we have a few responses. Sorry, I was counting who's all here with us to see how many have not completed yet. Okay, we can go into our next slide, and I will hand it over to Darlene and Esmeralda to get us started.
Yes, thank you very much. And I just want to say thank you all for being with us here on a Friday. I know that there's a holiday coming up and many people are getting ready for that. So again, thank you. I appreciate your time. I hope that we're able to provide everyone with what's needed to understand, why screening matters. So having said that, we're focusing on screening with strategy, okay? Which is really that front door to ECM. You're not just screening, it is an intake. It is your first care coordination intervention for ECM. If we get this right, we enroll the right client, we avoid duplication, and we set up strong care plans from day one. Now, if we're not doing this in a way that's double checking, then we are risking compliance issues. Of course, duplication of service. And then there's this confusion across systems and sometimes with partners. So you are the gatekeeper of ECM, and it's important for you to remember that when you're doing the screening. We're wanting to ensure that you have the correct eligibility for the population of focus, and also, that medical necessity is supported, that you're improving some of these care coordination supports from day one, and it's a way of protecting your program compliance. Next slide, please. I hope I get everyone's kind of participation on this. A little bit of an icebreaker, way to kind of see where we think we are at this point. And so my patient scenario today is we have someone who's had 3 ER visits in the last 3 months. They're diabetes. They have been diagnosed with diabetes, excuse me. They do have stable housing, and there's no known BH interaction. Yes or no, simple yes or no. It's okay. Feel comfortable to in the chat. Would you screen them for ECM just based on this criteria? You can also state, I need more information. Thank you, Patty. Thank you, Alicia. I'll wait and see if I can get a few more people to be brave enough to share with us. Thank you, Dulce. Perfect. All right. Well, having said that, you are all correct. Yes, we would. And I think one of the indicators here is that you had 3 ER visits in the last 3 months. So definitely you would want to start screening at that point. All right. Didn't say necessarily enrolling, but screening is important. Next slide, please. Great job, everyone. All right. So by the end of this presentation, we hope that you're able to screen for eligibility across all the populations of focus, identify services already in place, which is very important, use tools such as Jiva and the provider portal, document correctly, and be able to connect screenings directly to your care plans. Okay. This is all about making your workflow smoother and more confident. Next slide, please. Perfect. Okay, thank you. All right. So let's ground ourselves. In your role as ECM, clarity prevents a lot of confusion. And I know that I've heard from other agencies that, they're not sure who is the lead. And so oftentimes that's the duplication that happens. An ECM case manager, as an ECM case manager, you are the front line for screening accuracy. You are not making clinical diagnosis, but you are absolutely responsible for making sure the right information is gathered and interpreted correctly. Gathering accurate intake information means that you're not just collecting answers, you're listening for the gaps in the services. If something doesn't make sense, your job is to ask follow-up questions or flag it. And an example of this would be like client saying no housing issues, but a referral is mentioning homelessness. This is something that you probably want to clarify. And maybe for the individual, being homeless isn't an issue and not something they want to address at this time, but again, something to note. You are building the foundation of the entire ECM case here. Reviewing available data, I think this is very critical, and a lot of times this is a step that gets missed. Available to you, not rely only on what the client states. So oftentimes the client may not know that they have, several other programs, and the best way to utilize and assess is through Jiva. So you're able to see in Jiva a few things. Utilization, so this is like EHR visits, admissions, diagnosis, again, in existing services. Jiva, as many of you may or should know, is the software that's utilized by the Central Coast Alliance for Health. If you skip this step, you risk not only enrolling someone incorrectly, but there also may be another agency that's been assigned to ECM. Identifying risks and needs early, okay? So you're doing a quick but meaningful scan. What's unstable? What's urgent? Where are the gaps? And this will help you answer things like, does the person actually need ECM level care coordination, or is there another service that would better suit this person? You are, again, not diagnosing here, you're identifying patterns and concerns. When you're flagging duplication and concerns, this is important for compliance. You should always be asking yourself, is someone already doing this work? Is there a program that overlaps with ECM? If you're not expected to solve it alone, that's okay, but flag that so that you're able to understand what other programs, what other agencies may be a support system for you. This is again going to minimize the duplication of other services and have a clear understanding with partner agencies. Documenting clearly. Your documentation should tell a clear story. what you reviewed, what you found, what you're unsure about. And think about it this way. If someone else picks up your case, can they understand why you made the decision you made? Clear documentation protects you and the client. Okay. Now for clarifying clarifying boundaries. You are not expected to make final clinical determinations here. You are not diagnosing or making the final eligibility. Your role is to gather information at this point. All right. And then again, remember that you're responsible for ensuring accuracy, doing the cross-checking that's necessary, and not assuming or going based simply on what the client is stating. Next slide, please.
I think we're having a little technical difficulty with the
Technical
slides.
difficulties.
Okay,
While
and
they're putting the slide up,
okay, go ahead.
yeah, I'll go into the screening framework. It's nice to have a visual, but for now, I'll just go into, there's 4 different types of screening that supports this. All right. So eligibility, again, just a quick check. Did we ensure eligibility? The population of focus identification. Are we ensuring that the population of focus is the correct one? Do we have a clear understanding of risk and needs? And then again, with Jiva and some of our other tools, are we ensuring that duplication is not happening? Think of this as your screening flow in your head every single time, these 4 areas, and that should be enough to kind of walk you through that first step. Next slide, please. And I'll hand it over to Esmeralda now.
Thank you. So we went ahead and had added on this some folders, some tools that are added into the chat. So those of you who would like to kind of take a look at those as we're going through the presentation, we created these tools for everyone to just kind of use as guides. So please feel free to add in the chat if you're not able to access it or open them up, but these will be sent out to everyone to, again, help with the guidance. So coming into the basic eligibility, this is your first checkpoint. As Darlene mentioned earlier, we do want to verify enrollments. Before we even get started, we want to really make sure that we do these basic non-negotiables as we are reviewing the documents and our checklist when we get initial referrals. When we are talking here about screening and we are talking about that initial first referral. This is how every agency gets their referrals in different ways, but we are literally speaking about somewhere down the line, someone has identified someone that needs ECM level of case management services. What do you do when you first receive that first referral, when you receive that communication from someone indicating that someone is eligible for ECM, it's needing those services? So like I mentioned, this I will call your non-negotiables. These are things you really want to verify before you even start contacting to do outreach to explain this is the ECM services. Before you even get to that point, this is where you really want to kind of focus some attention to. So our basic Medi-Cal Alliance enrollment. I know we have in our county Kaiser services. We are really going to focus on Alliance, who the majority of us is enrolled with and providing ECM contract services for. So really do want to acknowledge there are other ECM providers in other counties. There are other managed care organizations, but for this presentation and the tools provided, it is really geared towards Alliance and enrollment. So first things first, we want to make sure they have Medi-Cal. And we also want to make sure that their Medi-Cal is enrolled into the Alliance program. because that is who is managing the services for, and those are the guidelines that we are following when it comes to how we are providing the services. Um, so if no active Medi-Cal, then we would should stop services, and then we can start kind of working with the families if there's another referral system or something else that we can do. Um, Next, sometimes this doesn't kind of pop up as one of the things that we really want to verify, but we want to verify the correct county code. Santa Cruz County in Medi-Cal services and Jiva in running the provider portals. Whatever the source that you have to verify eligibility for Medi-Cal, you are identifying also the county code. So Santa Cruz County, we are county code 44. Monterey County, we're county code 27. San Benito County, we are county code 35. The reason why the county code is important to verify, a couple of reasons. One, you got to see if your organization has the capacity to serve a member, a client in one of those counties. And the reason that's also really important is because, as you all know, when we are serving anyone with any kind of Medi-Cal coverage, we are really working within that county and the benefits within that county, because those are usually the ones that are being covered. So being knowledgeable about which county you're working on, and if you have the ability to support someone in that county, are you in Santa Cruz? Can you drive to Salinas? Can you drive to Soledad? Like, very logistic information is always very important because you want to really verify if that's something that is doable with you as an agency. Um, the other one that we want to really confirm and verify is that they're not already have another ECM provider. We want clarity on this. Sometimes we will have families and referrals that come through that are asking for services and are really needing, but then they say we don't have a case manager, we don't have anyone that's helping us with any. Then you go into the Jiva, you go into the portal, and then you verify, and then you see there is an actual active ECM authorization for another provider. Best practice ethically would be to really refer that family, that client, into contacting, say, hey, you have another provider that is providing ECM services for you. Have you spoken to them? This is their contact information, and then kind of doing that. Another way to do that is notifying the alliance. We received a referral with someone asking for ECM services. Um, can you help connect them to their ECM provider? Other option is allowing them, the families, if they want to access ECM services with your organization, with you specifically, again, having that conversation and then giving them resources to contact the alliance to go through the process. But as we all know, you cannot have ECM services with two different providers. So this is one of those points where you want to verify that information ahead of time. And if that information isn't clear, I always say, always want to stop, verify, take that pause, take that moment to really check that information ahead of time. Next slide. Okay, so you've done the first step. You verify the basic non-negotiables. You know they have Alliance, Medi-Cal. You verify the county code, and you're good to go. This is a county you can serve, and you understand the resources in the county to support with ECM. And you confirm they do not have another ECM provider. What's the next step? We have to find our population of focus. Do they meet the criteria? In the handouts and tools that we provided, we went ahead and split it with adults and children's services, and I'll go a little bit more on those details, but some of that information will kind of narrow it down even with population of focus. So as we know, we have to at least meet one of those population of focus. Homelessness, unstable housing, instabilities, high ED utilizers. When we're talking about high ED utilizers, we are talking about preventable ER visits, emergency room visits, or hospitalizations. Any serious mental health conditions, any substance abuse disorders, justice involved, transition of care. So all of you are pretty familiar with our population of focus, and some of you have specialty in one of these population of focus. So just key reminders here. Your population of focus, it is your entry point into ECM services. So you verify the basics, and now you are identifying the criteria that would meet for services. You won't always have the big picture, but usually within your referrals, within just kind of the referral system that's being provided, you will be able to kind of gather this information. If you don't already have this in your screening tools, it's an important one to do when you're having eligibility criteria. Next slide. So I do want to touch a little bit on the differences when it comes to adult versus youth screening differences. This is important to touch on. So sometimes there's a common mistake that we'll be seeing with the adult screening logic that it also applies to youth cases. Adults for ECM usually are tied to another complexity. So they have their population of focus, and there has to be something else tied in, a complexity, a risk, a high utilization. You often see this with like multiple chronic conditions, frequent emergency room visits, and then any overlapping medical needs with social factors that might come in, housing, food insecurities, and so forth. So with adults, you're often going to be asking, is this person a high risk, a high utilizer? Do they meet one of our population of focus? Um, when it comes to youth and children, the eligibility is a lot broader. It includes child welfare system, it includes more system-based services, and it does not always require a complex medical threshold. So youth and children are more able to access these resources, are able to be eligible for the population of focus criteria more easily because it's geared more towards children youth services versus the adults that have a little bit more requirements for the criteria. The screening tools that we provided, again, we split it up having that in mind of the population of focus and who would be eligible for these. Okay, we can go to the next slide. All right, and so risk and need. So this is our next step. Once we've identified our population of focus, so we got our basics, population of focus, the next step is about getting into a quick and meaningful picture of what's going on. This is basically your first scan. This is not a full assessment. This is just the initial information that you are getting with the resources you have available to you. So you're going to be looking for key areas, any chronic conditions. Are there any medical issues present? Are they stable? Are they unmanageable? Do they have a primary care provider? A lot of the quick guides that you can do is when you go in to verify eligibility in Jiva, in the provider portals, and even some of the documents you have access to within your organization, you will be able to hopefully gather some of this information, at least have primary care provider information on there. Anyone with Alliance will usually have an assigned primary care provider. Behavioral health, any medical health needs or concerns, diagnosis, any suspicion of having any of those. That's important to just kind of consider. Substance abuse, is there any substance abuse history, any current history, anything that would be impacting their care? And then your social drivers of health, your SDOH needs. This is a big one for ECM. Remember, we're doing non-clinical support services. We are really addressing those barriers. Is there any housing, any food insecurities, transportation, any safety issues that are coming about? And these often drive the need for the care coordination. Again, you're linking all this information back to ultimately inform your care plan that you would be kind of following and creating as you go along. But the more information you can gather during the screening, during the assessment period is good information to have as you start creating this. So a couple things to keep in mind. You are not going in and you're not doing a deep dive. Again, you are just asking these questions as you are reviewing the charts. What is unstable? Is there anything urgent that's coming up? A lot of time the urgency comes up with the referral that you receive. Can you see any gaps in there? And the steps will really help you determine the complexity of the case, how quick you need to respond to it. We do have the requirement with the Alliance that when we get a referral, we want to start initiating outreach with our clients within the 5 business days is the good practice of where we want to be at. But again, you really want to see, does that mean I got the referral today? I need to respond to it tomorrow because there's some kind of a really high acute crisis need that we want to address. So this is really the part where you want to identify that. Okay, I'm going to tell next slide. All right, where do we find our information, our chart reviews? Most of you that are providing ECM services should have access to Jiva, should have access to your Alliance provider portals, and should have access to your internal referral information that is coming to you. Your chart reviews, like I mentioned, and it's part of the forms that were shared with everyone, might be able to give you utilization history. I will say sometimes the information that's in Jiva is not very clear. It doesn't have a lot of information. Sometimes it's not there. Disclaimer, those individuals that have Medicare and Medi-Cal, a lot of that information you might need to run it through your Medicare portals. So for those that are serving adult population, just kind of have that in mind that having access to running eligibility and authorizations and any of that information through your Medicare portals is also very valuable information you can gather. You'll be able to gather diagnosis, any behavioral health involvement, any hospitalizations in psychiatric facilities. That's also another good one to be able to gather that information just from the basics that you're able to get. Okay, you can go to the next slide. Okay, and this is one I would say is one of the most powerful parts of your screening, your utilization history. It's telling us the story. So you're looking for the patterns. You're just not counting the visits. You're looking at what patterns you're seeing in between. You're reading in between the lines of the information that is being provided to you. So the patterns could be is, yeah, you're looking for their frequency. Sometimes in your reporting in your Jiva, if you have someone with the high chronic conditions or high emergency room visits, you're starting to see, is there a pattern there? Is there a reason why they're going? Are you seeing some kind of history? You're asking them as well as you speak to your clients. Are they repeatedly being hospitalized? Do they have missed appointments? Where is the gap in the care that's being provided to them? And, this could be something that you are kind of really just kind of asking the questions to see if there's something that you can identify as one of the barriers. This also really supports your identification of the population of focus, your medical necessity, and you're identifying the level of risk, which are all crucial parts of meeting criteria for ECM services. This is one of the clearest ways to show why ECM is needed. And so, for example, 3 ER visits in 4 months and plus missed PCP appointments. What does this tell you if you're looking at it through that lens? They're high utilizers. They're having poor care coordination connection, and they likely need some more support in coordination with their medical providers. I will say, a lot of times you might not have this information, but sometimes even the families will tell you, your clients will tell you. But a big mistake is really ignoring the missed appointments, the preventive care appointments. So if you have a child that hasn't been making it to their well child visits, if you have an adult that has a chronic condition and you notice, hey, you need to manage this chronic condition, hypertension or anything, and you haven't been to the doctor in 6 months, what does that tell you? Gaps in medication refills. Sometimes when you hear someone explaining to you, like, oh, my medication refill is coming up, I can't get my doctor to refill it. You might ask the question, is your doctor requiring you to come in person to get that refill because they need to do a reevaluation? So just having that information really does kind of help you understand potentially what are patterns and can signal where you can come in as ECM case management to really support with those needs. Okay, next slide. This one is where we are screening for a duplication of criteria. You will all hear, those of you that have participated in our previous learning circles, I'm a big one about duplication and checking. We really want to make sure that we are not duplicating services and we are screening. Sometimes most of our screenings, when they happen, this is where an error usually will happen. like I said, basic screening, we want to make sure there's not an existing ECM provider. ECM services also has criteria for exclusions, and it also has criteria where you can only have one or the other, or you can, or you need to collaborate, and things to look out. So just make sure you have this check. The resource forms that we provided, I also kind of included some of that information in there to kind of work as a checklist for you to ensure that you are not duplicating with another program that is that you need to be aware of when you're working with families. So here I have a couple examples, programs you want to look for out for MSSP, the HCBA, the HIV waiver program, another complex case management program. You know, all of these programs are programs that you need to be either work with, it's an either or kind of supports. So I can go ahead and move to the next slide. I can go a little bit on that. Okay. So there really isn't a lot of exclusions when it comes to ECM services. However, there is a hard stop. This is an auto exclusion. If someone is enrolled in hospice, hospice will be considered an auto exclusion per the ECM guidelines with the state. And another one would be and already has another ECM provider. Again, you cannot duplicate the services. So if when you are verifying anything, you see that someone has hospice services, this is where you stop. You want to verify to confirm if in fact they are enrolled in hospice or if they have another ECM provider, and then you document the reason for this. This one is tricky. Sometimes Jiva, you will be able to see that they are enrolled in hospice organizations. However, I'm speaking for our older adults. Sometimes their hospice benefits are covered under their Medicare. So again, if you have access to their Medicare eligibility portals, that's a good place to check if they are already enrolled with the hospice agency. We do have some individuals that have only Alliance on Medicare and will be enrolled on hospice services through their Medi-Cal services. Again, that's something that can be verified, but it's not very easily done. One thing that can help is if you ask family members if they are receiving any services through one of the hospice organizations. So can move to the next slide. Okay, let's talk a little bit about either or programs. They cannot be, you cannot provide the ECM services at the same time as these other programs. So MSSP, this is one of, for our older adults, it is considered a case management services. And you would have to coordinate with that. We have some of our organizations that do provide the MSSP program and ECM services, and they have a good way of kind of transitioning, but this is through the county, this is through adult aging services. Our HBCA waivers, these are homebound waiver programs. Again, this is a Medi-Cal coding system that's in there. You can verify, but any individuals that you have that the way you can kind of have a guess of if this is something that they have these services is individuals that have a developmental disability are receiving SARC services. So if someone is receiving SARC services, you might want to ask the SARC coordinators if they are on the waiver, on one of these waivers. The self-determination program, again, anyone with a developmental disability, anyone that has some level of supports that are needed that might be covered through because of their diagnosis or medical conditions would fall under these programs, but there is ways to verify. Unfortunately, the systems that we have mean that we are calling sometimes these organizations if we have a suspicion that they might be receiving these services. And again, the tools that we provided does provide a little bit more resources and a little bit more explanation of what these programs are. And then the other one, as you all know, the Alliance has a complex care management program as well, which is considered the transition down from ECM services. You want to verify if someone is enrolled in those services. It's a little bit easier to confirm that with the Alliance because if they authorize an ECM service, it's usually because they're not receiving that with them internally. But again, these are the ones that we want to really make sure that the clients, and just keep in mind, if they do have one of these services, the clients like MSSP, for example, and they say they would rather have ECM services, with one of you, that is their client choice, and you could always kind of help provide the information of how to do so with the changes. Okay, go to the next slide. Okay, and then programs that require coordination. So these are programs that you can have ECM and be enrolled in one of these programs. So behavioral health services, the FSP programs. Some of you might be familiar with them, some of you might not, but I do get asked which of those are. But the FSP program is really an intensive community-based mental health program with California that is designed for individuals with severe mental health conditions that might be unhoused or at risk for homelessness, or those that are involved in the justice system. I just named out a lot of our population of focus for ECM. So this is just kind of being mindful that there is other groups, other case management programs that provide almost the same level of support. So again, you want to come in as enhancing with your services, not replace them and not duplicate them. So care coordination with these are really important. CCS, whole child model. Again, these are programs that you can verify with the Alliance. It usually will pop up on the eligibility because these are programs that are also supported by the Alliance. And then school supports for those of you working with adolescents, youth. Some of the information you might be able to gather that will help support your chart reviews and so forth is IEPs, counseling, 504s, any kind of school records that might also kind of give you a little bit of a glimpse of what services they're being provided, but can also kind of see where you can come in to support with any gaps. Okay, next slide.
All right. Thank you, Esmeralda.
Thanks.
So we've talked a lot about duplication, so I'm not going to stay very heavily on this slide, other than to say clear role identification is so valuable. Understanding you are the ECM lead care coordinator. Make sure that if someone is already assigned to behavioral health services, what that actually looks like and means in practice, because there may be some gaps in the services that you could complement. So just because they have BH doesn't mean that they're not needing some kind of care coordination or support with BH services. Next slide, please. Thank you. All right, so documentation does matter. This is where everything comes together. Your documentation, again, tells the story of all the work you did in your screening. And if it's not documented, we all know it did not happen, right? So when you are about to start your note, remember these 3 key questions. What did you review? What did you find? And why does this client qualify? Or maybe why do they not qualify? Okay, let's break this down. Your chart review via Jiva indicates 3 ER visits in the past 6 months, an asthma diagnosis, and housing instability. Client most likely population of focus for higher utilizer with SDOH needs, no active duplication programs identified, further assessment required. Okay, so that's all there. That has the data source, which is ensuring through Jiva, utilization, identified 3 ER visits in the last 6 months, their SDOH, housing instability, a diagnosis that qualifies as also asthma, and again, identifying and reiterating that no duplication programs are being provided. There's no red flags if an auditor were to come in and see this note. So this is a quick example. There wouldn't be any questions asked, again, if it being audited. So bottom line here It's good documentation, shows your thinking, and it protects the work that you've done. All right. Next slide, please. All right. So we have some common mistakes here. All right. And some of these mistakes are not because you're not working hard or you're not thinking big picture. It's always about rushing or assuming. So I often say, let's take a pause when we're doing the work, ensure that we are identifying all the different stages of the work that we've done. All right. So again, we've talked about it a lot in this presentation, ensuring the duplication isn't happening. We don't want to assume. We don't want to forget to check Jiva. I think Jiva will be your best friend. If you're not comfortable utilizing Jiva, it's important for you to start. Practice, get in there, kind of see what kind of resources you can really get just from that. If you're not checking Jiva, you're not checking utilization, you're not checking enrollment, and you're not checking the different services. Okay. Are all your waivers in place? Are you missing a BH waiver or a confidentiality waiver? These are often hidden somewhere in a chart, so make sure that you're cross-checking and screening that those things are there, and if they're not, that you're supporting putting those in place. So those are all very important things, okay? Are we noticing any patterns? Are we skipping steps? Are we making sure that we're verifying often and always? All right. Next slide, please. Okay. So this is that connector. Esmeralda has talked about the golden thread often in her presentations, but this is the connector of all the work that you've done in screening, and we're not wanting to separate it from the actual care plan, right? So what you're gathering now from all the screening tools and all of the things that you discovered when creating your templates, you're going to see what areas do I need to explore more deeply? What are the areas that the patient is really wanting to start with first? How are you going to work with this client? Is this a high need client that needs to be seen once a week? Is this a client that needs to be seen 3 times a week? Or, connecting with them several times within the week via in-person or telephone? When you're walking through housing instability, you're wanting to actually just make sure that you're clear on what their needs are and what the needs of the care, that they're all outlined in the care plan, that you have all referrals are there, and all the outreach that you're completing or collaborating with someone to ensure that these needs are being met. If someone is is often in the emergency room, what care coordination needs to happen to support them being successful? Do you need to connect them with the PCP? What other kind of support is needed so that you're reducing the amount of unnecessary emergency room support? Like is there other ways? Can we have them call a crisis line, or are we asking them to call a doctor, schedule an appointment with the doctor a few days? Is this something that needs to be assessed immediately or not? Next slide, please.
Okay. So I do want to get everyone to just kind of, a real life workflow using the tools again that we are providing on here, and what you should actually be doing. So quick, practical workflow kind of check. You're checking the eligibility population of focus. You're going to review utilization. You're going to identify the risks. You're going to check for duplication, and you're going to document your findings. These are your initial screenings that you're doing, and you are really kind of capturing all the information. Then this is when you begin your outreach. So this is the steps that you should be taking prior to initiating and starting outreach. There is opportunities, and every organization is a little bit different in how you kind of have the setup, but the initial screenings honestly do not need to take that long. Sometimes we have support staff that are able to just kind of even initiate that part of the whole process. Um, I wouldn't recommend that you flip this order. I think if before you start doing your outreach, it is really important to have all the key information ahead of you. Because if you're missing some information, just as the basics like contact information, um, do you know how to get a hold of your client? Do you know how to reach them? Is there a phone number? Is there something you should be aware of? A lot of that information is done kind of part of that pre-screening process. Um, This is also your prepping. So just kind of consider this your prep, your ability to prep to just kind of get an understanding of your client and what you're going to be doing. When you do this kind of level of prep work, it also helps with your engagement, when you're doing your engagement with them, you're doing your outreaches. A lot of times it ends up being just confirming information. So you don't have to be asking them to relive information. You don't have to keep asking them when you finally get to that outreach point. It makes it also very helpful because you're not spending too much time asking them who's your primary care provider, for example. You already have that information, you're just confirming versus them potentially saying, I don't know who it is. Let me find their card or let me find, sometimes that information is not readily available for them. So just having this ahead of time really kind of helps with the process when you start doing outreach with individuals. Um, so just quick question for everyone. And be honest, add it in the chat. You can unmute yourselves. I know we've been giving a lot of information, but how many of you actually do something similar to this of screening, checking everything before you do the outreach, or do you wait for later? Does everyone have potentially a screening checklist or flow where you verify all this information beforehand? Abdul said no. Okay, thank you. Anyone else brave enough to? Yeah, we check eligibility. Thanks, Patty. Yeah, so I think it's really important just to kind of consider all of this. As a referrals processor, we do everything, but risk identification is for our checks to transfer details. Exactly. So someone's checking in. Thank you, Juliana, for that. But yes, everyone usually with ECM eligibility, it looks like it is something that each organization has some level of verification for the screening. Next slide. All right, so I do want to walk you all through potentially what this would look like in a real quick kind of in practice. Again, recognizing that a lot of information might not be readily available for you, but it is really using what you do have access to verify information. So here in this scenario, what we know about your client. So it's being sent to you by a referral, maybe has that information available. You kind of verify. So we know there's 4 avoidable ER visits in the last 5 months. They have a diagnosis of asthma. They've confirmed that there's missed PCP visits and there's possible housing instability. So the questions you are going to be asking when you do your quick screening is, you don't have to overthink it. You don't have to, just kind of have this mindset as you are looking into what you want to do. So the 4 steps to this quick framework is you are verifying eligibility. You're going to verify population of focus. So in this scenario, yes, there's very likely high utilizer with SDOH needs. We don't know what they are. We don't know what the situation, but we have information to tell us that this person, goes to the emergency room and has had multiple emergency room visits in the last 5 months. Um, there's a chronic condition, so we have asthma, and then you've also have the information that they've been not going to their primary care. So is this something that potentially will be supporting and could meet a population of focus? Yes. Duplications and concerns. So here is you've checked your Jiva for the portal and you see they're active ECM with another organization. And then you've also are able to verify that they are being provided services by another organization, a waiver, they have a waiver, Medi-Cal waiver, they have an STOH, those kind of situations. Um, and then you also are verifying that if they have another behavioral health provider. So these are a couple things that really are important to just kind of consider and make sure that are part of your screening. Risk, you're identifying a medical risk, you're identified uncontrolled asthma, you've identified repeated ER visits, the care gaps, and the SDOH, again, the housing instabilities. So this is the initial referral. This is the things that have come up that you have. So now your next step is you're verifying the population of focus and you're in Jiva. You are reviewing everything and then at that point, this is where you begin your outreach. Okay, next slide. So the screening tools. So everyone has the screening tools that have been provided. So this is the recommendation of how you potentially can utilize the screening tools just to gather that information, the initial one. So first you would start with the chart review checklist. You're again reviewing your utilization, you're checking any diagnosis, and you identify any risk and duplications. When I say chart review, again, you're using the resources available to you within your organization. If you're in a school site, you're using IEPs. If you are working for an organization that provides population of focus for unhoused populations, sometimes you might have access to the individual's housing situation. So use what you have and gather as much as you can within what you have available to you as part of your chart review list. Next is the screening tools for adult and children. Again, you're confirming eligibility, you're capturing the needs and risk, and then you're going to start preparing for your outreach. In the tools that were provided, you have the outreach. This is the engagement to your client. This is where you're going to begin your care coordination of steps. This also, in the tools that were provided to you, all has even a tracker. We have the in-person requirements, we have the virtual, the telephone, any other modalities of requirements. This is a good way to kind of track your outreaches as well. So that way you know you are in line and then with the timelines that you're being provided. And then the benefits of using this process is you're complete and accurate for your screenings, the consistency with the compliance and the workflows, and then the careful confidence and confidential in the outreach that you will be providing to your clients. All right, then can we move to the next slide? So let me just kind of, speak a little bit to the key takeaways that we are having with this whole presentation, and just kind of want to hear something from everyone. So screening is the foundation for ECM. Your screening is strong. Everything that you will be gathering, this is the foundation, this is where it starts. And it's going to make your job a lot easier as you are gathering more information for your assessments, your care planning, and your engagements. You always want to verify the enrollment. Again, this is super important. You're checking for duplications. This is not optional. We really want to make sure we do our diligence to check. I know we don't have this information always available, but ask the questions. And sometimes I will say, if you are working with a client and then it turns out like you've enrolled, you've done the service, and then you find out that your client is actually enrolled with another organization, document that you've discussed you've had the conversation with them, document that you've let them know that you can't have both services, give them the information of who to need to contact to be able to move forward with any kind of changes in services if needed. And then you're also going to really be using that data and your clinical judgment that comes through with being able to do that. And again, there is a couple examples of the documentation of how you would do that. Okay, and next slide, I'm going to hand it off to Darlene.
All right, so we do have time for discussion and questions. Let's troubleshoot together. I'm not sure if you were able to access the screening tools that we created or the checklist. It looked like it said it was unable to view, but they will be emailed to everyone who's attending today. Quick question: what are the hardest things about screening for everyone? And it's okay to be vulnerable. This is a fairly new program. There's so many different types of screening that have to happen. Anyone either off mute or in the chat want to share what are the hardest things about screening for you?
I think for me, it's been because I came from a population of folks that was unhoused. So I felt like that was definitely high need. Whereas here, most of my families are housed, but they are suffering from like food insecurity. And so that's already, meeting the criteria essentially. So it's just, it gets a little bit complicated because I feel like, oh, like, I don't know, maybe it's not enough. I
Yeah.
question myself a little bit there.
Patty, thank you so much for sharing. I appreciate you being so vulnerable. I also want to say that you're not alone in this. We absolutely have a lot of people, myself included, where you've worked with the population of focus for so many years that a lot of the screening becomes routine. And then once we transition to another population of focus, it's just taking a step back and kind of unlearning some of the things that we did for so many years automatically and utilizing things such as this checklist that we provided that ensures that you're addressing all areas for screening. Anyone else want to share? On off mute or in the chat is fine. And that's okay if you don't feel comfortable. I think that Patti also shared where she does get stuck. She had a frame of only working with the housing insecure previously. Where else are individuals getting stuck?
Hi.
Hi.
I don't have a screening stuck situation so much. I'm with the county health services, ECM. Our referral situation is very specific because all of our referrals come from our, generally our clinic providers, sometimes from behavioral health, sometimes from some of the CBOs. My question is a bit more about the documentation. The system we have follows everything you have, except the documentation part in terms of screening somebody out of ECM. We have just in-house trackers. We make notes on it, and we will make notes if it's a clinic provider who made the referral. I've been given access now. I can make a note in their chart. Is that sufficient documentation in, just like a note on a spreadsheet and a note in their medical chart? Because we don't have a EHR for just getting referrals.
Yeah, so in regards to the notes, like if someone's not eligible for ECM, it's always best practice in clinical practice to really close the loop on that and, notify the referring party of, they don't qualify for, especially if they don't qualify for ECM, because I've seen where some BH providers or medical providers are insistent that someone needs to receive the services or might, in their judgment feel that this is crucial. One of the things here as well that you will see is that sometimes, even if the service they're eligible, you've done the screening, I think the families will still say no. ECM is a voluntary service. So to answer your question, yes, typically that's something that can be done as long as you have some level of documentation indicating that the referral was closed out, something, and what was the outcome of the referral is typically the best practice.
Okay, yeah. I wasn't sure because when we do accept somebody for outreach or enrollment, we have Activate Care. So that all of that is documented there. but the
Mhm.
things that I do aren't documented there, but I do close the loop and let the providers know,
Mhm.
why we didn't accept something or when we do accept something.
Yeah, and that's super important to do. I will, one of recommendations when it comes to also closing the loop on that is, just being mindful. I know our EHRs are not always the best, but I know in Activate
Mhm.
Care, and when you start doing outreach, we all know that doesn't mean that they're going to accept the service or they're going to go with the service. Outreach is really just to introduce the program and the benefits of the program. Um, and in the forms that we've shared with everyone, we do have a section there where it does kind of have that level of overview for everyone to just kind of mark down. Even if you don't already have it in place, there's something there that kind of says what was the outcome of the referral.
And I
Okay.
really want to thank you for
Yeah.
your comment and question, because I think that we're all infamous for having to utilize several kinds of platforms to
Yes.
document. And
Mhm.
Activate Care, I know it very well. It doesn't always read friendly with our EHR systems. And so, unfortunately, to just add to what Esmeralda said, you would want to put that in your documentation in your EHR so that it aligns. And then if it comes up again at another point where that family or that patient is now ECM ready, or um, has now the criteria to qualify them for the program, you'll understand that some of the screening had already happened, and then the why, because I mean it can change as life does often. But yes, unfortunately, you'd be documenting in both Activate Care and your EHR. But great question, and I love that feedback.
Okay. Well, thank you.
All right. So this is a big one, and it's interesting. Esmeralda and I had a discussion about duplication just yesterday. What are you all seeing as far as the duplication of services when you're doing your screening? Anyone want to be brave enough to unmute themselves or even share in the chat?
Or have, and just to add to that, how are you verifying duplication? Is there a way, a strategy or something that any of you use? Um, any platforms, anything that kind of helps give you that information? Full
Maybe
disclaimer,
something that we didn't mention.
yeah.
If not, that's okay. We're really we're trying we're trying very different methods of getting engagement and interaction in these learning circles. So we wanted to ensure that we had put some time in to have this dialogue if needed. But to wrap this piece up, good screening is going to get you better outcomes and stronger compliance. And then it will become just practice for you to really understand and support the wonderful work I'm sure you're all already doing.
Yeah. And then for those of you that have seen the form or have been able to access it, is there any questions that come up for anyone as you're looking at the tools that were provided? I know some questions usually do come up around some of those screening tools.
I don't even know if they were able to get access, so we
So,
can pull them up and share if needed, but it says the file is restricted. Thank you, Patti.
okay. Memo, can we get the one of the forms up, maybe the checklist up? We can review it briefly since we have a few minutes. And that way we can touch a little bit on some of the
Yeah, and
questions
while
that
he's
typically
doing
come
that,
up.
if you could just also go to the next slide. I just want to make sure
Mhm.
that you see that we do have some additional resources and recommendations. The Central Coast Alliance for Health will be
Mhm.
doing some trainings coming up. So if you want some reinforcement of, again, and complementary kinds of education, you can connect there. And then again, the Jiva portal, the link is there for those who maybe want to get more resources. There's a lot of great information you can find in there.
Yeah, and then for the Alliance resources recommendations, so these that we outlined here are really in line to the presentation we had today in regards to understanding ECM overviews. We didn't go into much detail over the specifics of population of focus since that's been done in the previous learning circles, but there is trainings that the Alliance has really focused on with the shared care planning and non-duplication services. The Jiva portal on the Alliance, the frequently asked questions really does have a lot of resources on how to navigate it for those of you that might not use it. And that's something that can be important and very useful for everyone.
Yeah, so Memo, at this point, would you be able to pull up the checklist for us so that we can maybe walk them quickly over that form at least? Thank you, Memo.
All right, let's see. Can make it a little bit bigger. There we go. Can everyone see that? There we go. Okay, so when it comes to ECM, like I mentioned earlier, and we were talking in the presentation, we have the basic information. So this is really meant to serve as a checklist. We can go scroll down. So this is your review, your documentation, your referral information, your assigned PCP, very basic information that you can find. If you go down, population of focus, and your ECM referral, like is there a presence for that? Who sent you the referral, so forth. So again, we go a little bit more in detail on this checklist. If you go down more, so this is again utilization. We're trying to see do they qualify under population focus for with their history. So I always say you're putting the puzzles together. You're trying to find the information that is available to you. So ER visits, inpatient. So these are a lot of information that really kind of helps justify and provide the medical necessity for different population of focus. Medical, if you go down for the medical review, chronic conditions, any medical history, any barriers to the documentation, missed appointments, any follow-ups, refills. Again, that's just something that is good information to have. Go down. Okay, behavioral health. I mentioned before, we really want to see what information we can have around this, any current BH providers. I will say if there is a client that you are doing the screening for and you feel that they're going to be eligible, they meet all the criteria for ECM services, it is a good idea that usually once you start doing your outreach, you bring with you release of informations, and your first ones that you want to have release of informations will be for primary care providers, because that would be your first initial touch of contact for coordination, is making sure that you are coordinating with our medical providers for any kind of medical, because that is one of the key components. If you go down, we have the social determinants of health. Again, these are the cues. These are all the clues that you would be kind of trying to verify if there's anything in there that you can use. And if you go down, so again, breaking it down to the different parts. And if you notice, a lot of this information is also information that is part of your care planning, your initial intakes. If you can get this information as part of your screening, a lot of it just really makes it easy to have that conversational intake with your clients, and you're able to really kind of incorporate it within your intakes of verifying and not having to be asking multiple questions, being very trauma informed. And then duplication, you're verifying if it's visible, if you have any of that information available to you. Okay, can go down. And then coordination. This is where you're going to check to any specialties. In Jiva, you will also see referrals to specialty care. If you will see referrals to home health. You will see a lot of other information there, any school document, anything that needs to be, sometimes you'll be able to access that. Like I said, for those of you that have clients that are serving that have Medicare benefits, you might not see this in Jiva. You very unlikely will not see a lot of that because your Medi-Cal benefits is your secondary, and if you have access to their Medicare benefits, you'll be able to find eligibility on that. Okay, Emma, do you want to just skip over to the next one of the other tools? And the rest is just the safeties.
And again,
Anything?
we created these tools to help and guide, and at some point maybe you won't need the tool at all, but these are just ways to help you make sure that you're addressing all of these areas when completing your screenings.
Any questions on this tool that comes up for anyone as you're looking at it? All right, and then we can just review real quick the children's and youth one, Memo, if you can bring that one up, and then open it up for questions. Just want to get some clarity on a few questions that usually I see come up. Thank you. So children's youth, again, we're really kind of the referral source is really important because that gives us a lot of information. If you go down, it will say current location. I will just stop right, go up a little bit. There we go. Current location. So when we're talking about current location, it's Memo, if you can go up a little bit more or down. There we go. Current location. I will say a lot of times it's not very clear in the documentation, but you can always use the information that's provided as hints potentially. So one of the things that I sometimes will look at is the home address. That gives me the county code. That will give me information about where about in the areas that they live. Sometimes you will see addresses that might be the shelters. Sometimes you'll see previous addresses that might be locations that you are familiar with in the work that you're doing. So Patty, I hope you don't mind, I'm using you as an example. You work with unhoused populations, so sometimes you do recognize certain addresses for certain locations that you know are locations that are services that are provided for individuals that might be unhoused, for children, and so forth. And I think those are really important to just kind of consider and have in the back of your mind as you're reviewing these charts, because that can also give you some information that might not be as clearly stated in there. Um, Share of cost. I don't know, some of you might not be familiar with that, but sometimes we will see Medi-Cal benefits with the share of cost disclaimer on it, where it basically means that it's almost like a co-payment that needs to be made. They have to meet that amount that's in their insurance eligibility before the full scope services come about. So those of you that are doing services and you run across this, just kind of be mindful that you might need to do a little bit more verification with the alliance, because if some families are not able to meet what they consider that share of cost, that means that those services are not going to be funded because they don't fall for the full benefits. So just something that I added on there just to verify. And if you go down a little bit more, the other one. So population of focus, we all know what those are. So we're just going to skip through those a little bit. If you go all the way down more. And more down. So I can stop right here. So again, this is part of the chart review, clinical, developmental, and social needs, quick snap. Durable medical equipment. This is something that you would probably be able to get off the Alliance portal because you can see if there's been authorizations for any medical supplies that are being provided for individuals. So something to keep a lookout for. Anyone that might have any SARC services, that's also a hint that you can take that. There potentially has been some eligibility for a developmental delay. We go down, and then that kind of really helps kind of dictate like where you're going. School services, again, this is kind of really serves as that checklist and that risk of identifying, and then our strengths and supports. We can go down a little bit more. Go down, and I just kind of want to make sure we kind of touch a little bit on these. The duplicative services, if you want to go down. Okay, Any questions on these for anyone? I know some of these are not stuff that a lot of you might not be familiar with, but when you are reading this, would you know what these different services might be and what they look like?
I know Esmeralda talked about some of these in her presentation, but don't feel um, taken aback if you don't know what they are.
Mhm.
This is an opportunity for you to kind of get clarity if you need it.
Yeah. Okay. And then I see in the chat, Alicia, that not everything, yes, that is clear. Not everything is in Java. Um, it's putting the pieces together. There is some individuals will have more information versus some other will, you'll go into the Java and it's absolutely blank. There's nothing there. Um, difference between ECM and complex, they're both provided by the Alliance. Yes, they're both funded. The Alliance as a complex case manager is considered a lower level. So when you are graduating someone out of ECM services to lower level of care, usually the flow would be going down to complex care management services. And the Alliance, like I mentioned, they have their own this part of the services that they can provide. Complex is, I would say, those services where the individuals are able to, you can reach them over the phone, you're able to provide, they're able to kind of coordinate at a lower level versus the in-person and services that are provided through ECM. But keep in mind, you would have one or the other because they're both considered case management services. So you just kind of really be mindful that you can coordinate with them. Another one that falls under complex case management, I will say too, is our services with our nursing program at the county. So some of you will see with our new moms. So there's a nursing program that you have nurse RNs. You can have ECM with that service as well, but again, you have to just kind of consider that and make sure you're not duplicating and working in partnership with them. All right, any other questions?
I have a question about
Yes.
the different waiver programs because I'm not familiar with them. My case managers might be, so I wouldn't know where to look for that. And I'm not familiar with the program. So where can I find that information?
That one is a tricky one. I'm going to be honest, a lot of times with the waiver programs, those are, you would might be able to find it out with your alliance, so the region, your local regional center, which for us is the San Andreas Regional Center. A lot of individuals with developmental diagnosis will have waiver programs. Some of them will, some don't. Usually that's incorporated within the services with the alliance when they go into services. Not with the alliance, I'm sorry, with the SARC services. Um, the way most of us will find out is we will ask them. We ask family members, we ask the clients, we ask them, and they'll tell us, yes, I have a San Andreas Regional Care Coordinator. This is their contact. And then you can contact them and ask them if they're enrolled in the waivers programs. And then they might be able to give you that information. I haven't been able to find a way to find it with the Medi-Cal coding. So there's usually Medi-Cal coding waivers that you can do it, but sometimes those are outdated. So that's why I just kind of word of caution when you're trying to run the waivers. What you just kind of to confirm is that the best practice is that if you find out they have it, that's when you start kind of having those discussions with the family member, because you can have both. You just got to make sure you're coordinating with some of those services. Or if it's one of the specific waivers that it's either one or the other, again, you just got to coordinate. I think one of the examples we can have is someone that has independent living skills services in their home. So they have provided through regional center in the house, like round the clock caregivers. Those are safe to assume that they're under one of the waiver programs.
Okay, thank you for explaining that because
Mhm.
it's triggering. Oh yeah, I know what that is. So thank you.
Yeah, those are tricky. That's not an easy, like, how do you verify it? But it just read in between the hints. If someone has 24-hour care, that's usually my first hint that they're enrolled in some sort of a waiver program.
Great questions, though. Thank you.
Yeah. Any other
Um,
questions for us around this? We will have a training. The next one we have in the 24th training will be around eligibility, loss of eligibility coverage, what to do in between those, and best ways to support your clients in getting their Medi-Cal reinstated or eligibility services. What would that look like and so forth. So we will be preparing something for that as well.
and thank you so much, everyone, for your engagement. That means a
Mhm.
lot, and we appreciate it.
Thank you.
Yes, thank you, everyone. I wanted to make sure that we launch our Zoom poll. Let me get that back. Where'd it go? Here it is. All right. Yeah, thank you, Esmeralda and Darlene, for walking us through today's session and sharing those great strategies. And so we hope that today's session gave everyone some practical ways to approach screening, identifying existing services, and avoiding duplication in your day-to-day work. And so before we wrap up, we have that Zoom poll on launched right now, so we can get your responses. That would be great. And so yeah, your feedback on this is going to help us continue shaping these learning sessions so that they better support you. And then, like Darlene and Esmeralda shared earlier, we'll be sharing the materials within the next week from this session. And we do have that next session on the 24th. And so please go ahead and register for that. And we'll also share the registration link in our follow-up material so that you have that for the next session and then sessions following. And so, yeah, thank you all again for joining us, and we appreciate your time and participation, and we hope to see you at our next session.